Hello everyone. We'll be discussing today a very important topic, that is management of hyperuricemia. Treat patients, not reports. And I am pretty sure that during your residency, or if you are in practice, or even if you are doing internship or seeing patients, you have seen this very frequently, that patients are on this urate lowering agent, that is febuxostat or allopurinol, because sometime uric acid was high. It was high when he was admitted with diarrhea. It was high when he was or she was admitted with sepsis, or it was high because just a panel, what we say, diagnostic test, or there are packages like that, right? In that, uric acid came high, so febuxostat or allopurinol was started. I have nothing against those drugs. I just wanted to highlight that it's not report you treat, it's a patient you treat. So I'll be taking a very brief. The good part about this class is we have just 20 slides, so it won't take much time. I'll give more time to discussion if there are questions and all, so that will be a better way to go for this topic. The details of this topic, the crystallopathies, and as well as the updated management of gout, both have been covered and they are already available in our app, so you can access that. And now we will come to our topic. And if we go for this topic, the first thing comes that what is on the menu, what is the outline of presentation, what we are going to discuss here. So first we will see how does the patient come. And this is very important in current practice, that most of the time it happens, you are a medicine resident or you are a consultant, you get a WhatsApp report that this is my report, doctor, what to do further? Nothing to do further, please come to me, then we will do something. If you start your practice with report first, then the patient, it is very difficult. Okay, so that's a total crux of this class, that patient comes before the report, and it will always come before the reports, otherwise we will do a lot of mistake. What causes the high uric acid, right? That is a better way to treat this hyperuricemia rather than just treating every hyperuricemia in the world. When actually things goes bad, like the natural course, suppose if I am doing uric acid for all of us who are in the class right now, it comes high for few 5 or 6 people. Should we start treatment for those 5 or 6 people, or how we should go ahead? That is a very important point to take, right? So that doubt comes, like suddenly you see a report of 8.2 uric acid, and that left side it writes that more than 6 in female and more than 7 in male, something like that, which is more than normal physiological limit, and it is given in red. So patient relative or patient comes to you, sorry, this is high, what to do, right? So it's always a concern, and our reflex, sometimes a very bad reflex, because we have seen others doing that, prescribe Xyluric, or sorry, I won't use those names, allopurinol, prescribe febuxostat, right? We keep doing that. I have done that, but later I realized it was a mistake, and the later was not too late. Okay, but it is important to realize that how to go for that, and how do we manage this hyperuricemia. So it will be a very simple class. I'll be stating more and more fact and more logic. I hope that will make more sense for your understanding of this concept. So how does the patient come in your clinic with hyperuricemia? Majority of time I see them as asymptomatic patient, because they went to that fancy health checkup. They are on some medication which can cause hyperuricemia. There are secondary causes we'll be discussing. That is my main interest to rule it out. And so-called arthritis panel, right? Someone comes with joint pain. We send arthritis panel. In that, uric acid will be there, rheumatoid factor will be there, ANA will be there, anti-CCP will be there. And it's actually very funny thing. Okay, I will say it's a pure commerce, right? We have a given patient with a given history who has typical symptom or atypical symptom, where 1 or 2 diagnoses can fit. We cannot send panel. This is not CBC. Okay, even CBC is not a panel, right? It has importance and we understand it. And this is even an expensive affair. Forget the expense. It is illogical affair. So we should not go for that. If you read your Harrison, or if you read a book in nephrology or rheumatology about the uric acid chapter, or the this thing, from the time of Hippocrates, it was very clear. He has written very beautifully that before menopause, a lady will not take gout. And that is very important sentence to remember. If I have a 23-year-old female with multiple joint pain, if someone sends uric acid, it's just for fun. Okay, it does not make any sense. The gout does not come like that. Okay, so it is very, very rare. Always respect the given clinical scenario and then start investigating. It is okay to over investigate, but it is not okay if we do not know interpretation of that investigation. That is the total point of being a clinician. That if investigations are done, and sometime or most of them in practice it happens, it is already done, and then you are called that what to do about this. Then you have to use this a very common, simple practice. See the patient, take the history, do the examination, make your clinical impression, then see the reports. Everything will make sense, right? Second, with hyperuricemia, the patient of gout can come, nephrolithiasis can come, and urate nephropathy can come. That we are going to discuss in next few slides. Now, here I want to stress on a fact. During an episode of gout, uric acid can be normal in 33% to 50% of the patient. Okay, so someone comes with a very classic history that this is a gout episode, and then if you do uric acid, it comes normal. If you are not confident, your patient won't trust you. The doctor is telling me, not telling me right thing. How can my uric acid will be normal and patient is like doctor is telling gout? This will happen in practice, right? You should be enough confident enough to convince even that no, it can be normal in 33 to 50%. Why I'm repeating those numbers 33 and 50? Because somewhere it is written 33, somewhere it is written 50, and people like to make MCQ on that. Okay, so it has been already asked. So just see your Harrison, what is the exact number and follow that. It's 33 written there, but I've read 50 also in a very standard book. Okay, so the ultimate message was not to solve MCQ. Ultimate message was your patient can have normal uric acid during the episode of gout. A normal uric acid during the episode does not rule out the diagnosis. Vice versa, high uric acid and no symptom does not mean gout. Okay, this is all clinical thing. So we have to be very careful on that part. Tumor lysis syndrome is one of the dangerous cause of hyperuricemia. Call oncologist and nephrologist. Do not discuss even. Here, kidney will go in 1 or 2 days if we have not taken appropriate action. So this is emergency. Okay. Here your allopurinol febuxostate might not be enough. You have to go for asparicase. And all oncologists know this. It is just MCQ which makes it, oh, this is dangerous and all things. Okay. If you've really practiced in oncology ward, you will be well aware that how good they are in managing, right? But it is just sometimes we make a hype because questions are repeated on this. Rare things in life, they are actually rare. There are some pediatric syndrome and all where hyperuricemia can be there. Okay, so this is the overall picture. Patient who has uric acid level high, these are the chances one of the problem can be there. And I pointed out very correctly that 33 to 50% of the patient can have normal uric acid during the episode of gout. That's a point you have to remember from this. A second thing, nephrolithiasis. There are so many, like these cases are mostly dealt with urologists, right? And urologist involves most of the time nephrologist or a physician to analyze that what exactly is there in the stone, the uric acid stone, right? Or the calcium oxalate stone. So that stone does matter. The complexion of the stone does matter. Character or structure of the stone does matter. And uric acid stones are not the commonest stone to tell. Now, one more important point, uric acid stones, if patient has the uric acid stone related nephrolithiasis, it is not compulsory that they will have hyperuricemia. There are certain causes we will see in next few slides which will have hypouricemia. The problem, what happens with nephrolithiasis with uric acid is the problem at the kidney level, the acidifying defect. That is the problem. It is nothing to do with much level in the blood. It's a local process happening there. So if you judge it by the blood, you will be fooled, right? So these are the two things we will learn. Its slide is in a way heavy to understand, but this is the main slide. I will say this is how your patients are coming to you. These are few classical presentation of gout. You can see this is the joint involved, the first MTP joint, and then there is the tophi discharge which is happening. This was being treated like cellulitis for so long. This is not cellulitis. This is gout in a CKD patient. This is actually the image of FIT. Here also the gout tophi can be seen. This is a classic polyarticular gout. It takes a lot of time. Sometimes it shows our collective failure that we could not prevent this. Okay. And someone will say, okay, patient in the patient only does not come. I agree, but sometimes we have to be sure that this does not go to this. Okay. This is also gout tophi, and this is a very important sign. It's called double contour sign, which we may, which will helps us to make a diagnosis of gout on musculoskeletal ultrasound. Okay, most of the radiologists know this, rheumatologists know this. It is very simple things. It gives us a lot of confidence. Once we detect this, our diagnosis is almost sure. This happens specifically during the episode of gout when you have a normal uric acid, but if you can demonstrate this, your confidence is high and you can take your patient also in confidence. Okay, it takes some time before patient will start believing you. Till then, your science will help you, right? So this is the point to learn. Double contour sign in gout has been asked so many times in MCQ. So for that also, I think this will help you, right? Now, this is another gout tophi. Okay, so this is at the ear. You can see at the ear, there is a gout tophi. These are finger pad gout tophi. Okay, so this patient did not come to me with that there is a problem in ear or there is a problem in hand. They actually come with proper musculoskeletal or the joint problem. This were the finding there. It supports the diagnosis, right? So this is the way we have to take findings, not ki these are the patient presentation. Most of the gout patient presentations are joint pain that is in lower limb, that also in first MTP, right? And it is episodic pain initially to start with. Initial episodes are lower limb, then it progresses to upper limb, right? So this is the presentation of gout, what you can see. This is the one symptomatic presentation of gout. The second symptomatic presentation of high uric acid is nephrolithiasis. What can be the predisposing factor? Gout itself. Okay, and specifically what people say when you start urate lowering agent, if specifically they are uricosuric agents, then the uric acid excretion through kidney may increase transiently. That time there is a possibility of nephrolithiasis, specifically if hydration is not good. That we have to be careful. Now this is again important. Increased fractional excretion of uric acid. This is pure MCQ thing. These things are very rare. The genetic mutation of URAT1, glutenine or Fanconi syndrome, where you will actually see hypouricemia, but uric acid stone. Fanconi is not that rare, right? We treat HIV and things are not completely, we are not like we are unaware of that. That is not the scenario. We are aware of those parts. Hypouricemia is a part. Even though uric acid is low, but nephrolithiasis due to urate stone can happen, right? So that is a very important point, that this is all clinics. Over treating with febuxostat and allopurinol does not make sense all the time. Then there are scenarios like uric acid overproduction. We will see in chronic diarrhea also it can happen, in diabetes mellitus and metabolic syndrome, as well as tumor lysis syndrome. And this is mostly the acute presentation as a classical presentation of the nephrolithiasis, which can happen with this uric acid stone. So this is the second symptomatic or the clinical presentation of high uric acid. First was gout, second was nephrolithiasis, third is chronic urate nephropathy. I have a very simple question that you might have been posted in nephrology ward. You might have seen so many patients of AKI or CKD. Have you seen a single chronic urate nephropathy? Mostly answer will be no. Have you seen this in MCQ? Answer might be yes. Okay, so this is very non-specific thing, that it does not have any different symptom than other nephropathies. So all the time the biopsies are not done. If biopsy is done, then only we can make sure, okay, this is the diagnosis, right? So here it is a deposition of urate crystal in the medullary interstitium, which leads to inflammation, and inflammation is followed by fibrosis. It's nothing. These are the urate crystals, and this is nothing but what we say, there is a deposition of tophi in the kidney interstitium. Okay, the tophi in the subcutaneous tissue or near the joint. Same way, the tophi here. If there is a deposition, body will react. The first response will be inflammation, then healing or fibrosis. That's how the kidneys function goes down. How do they present? Renal function impairment, blind urinary sediment, mild proteinuria. We do not do biopsy all the time. If creatinine is 1.5 or 2, many times it is labeled as okay, unknown cause, and we just do the symptomatic treatment. And these patients, like most of the time, have some comorbidity, like there is hypertension, there is diabetes, and it is okay, this is labeled like that. Okay, so there the problem happens. If your natural history is not fitting, it is worth investigating that with biopsy, whether this is just a diabetic nephropathy or the other component is there. And see, there are no rules in life, both can coexist. Only point is, if this is there, then your treatment aggression may change for your urate lowering agent. Okay, and that becomes very difficult in clinical practice to convince someone that asymptomatic hyperuricemia must not be treated. They will tell you this logic. What if that biopsy, what if that kidney is getting damaged because of this, right? And then you lose your battle. Okay, you might be right, fine, but again, you have to use common sense that a drug which may not be required for 10-15 years, because the rule of urate lowering agent is once you start it, you don't stop it, right? So you actually have to balance that you really want to take drugs for 10 years, 15 years, or you really want to decide good. But everything is different when you do an institutional or the medical college practice versus private practice. It's not just science, but I stick to science when I'm discussing with you, right? So now we know that how a patient with hyperuricemia can come to us. Now, the second question, why my patient has hyperuricemia, right? Either they are overproducing the uric acid, means lysis of the cell, so many hematological conditions, hemolytic anemia, sickle cell, polycythemia, megaloblastic anemia, thalassemia, myelodysplastic, leukemia, lymphoma, multiple myeloma. The list is too high. Also, there are certain conditions, specifically psoriasis, sarcoidosis, metabolic myopathy, mitochondrial myopathy, where there is an overproduction of uric acid and hyperuricemia can be there. So what I'm trying to suggest is if your patient just on a health checkup gets hyperuricemia, you have to be careful that are you missing something or not. I can remember only one of my health checkup, which was I was part of that during my post MD posting, and we found one multiple myeloma with high uric acid and borderline elevation of creatinine. Okay, so it is something, it gives you clue that you actually see there what is happening. Now tell me, what is the classical presentation of all this part? Is it hyperuricemia? Not all the time, right? They have their symptom or they are asymptomatic. Asymptomatic, you may diagnose them during the screening, right? So that is the point. So if age appropriate screening is done, or if screening is done by a follow-up of a good physician, then only screening is science, otherwise it is commerce, right? We have to understand very importantly being a practitioner. Under excretion, which can happen in renal insufficiency, you see in most of your patients, dehydration and volume depletion, these are transient. You hydrate it and things gets better. Lactic acidosis, ketoacidosis, both overproduction and under excretion can happen during MI, congestive heart failure, and sepsis. Metabolic status like hyperthyroidism, hypothyroidism, hyperpara, hypopara, obesity, as well as the drugs like diuretics, low dose salicylates, nicotinic acid, pyrazinamide. There's a big list, but these are the common drugs which cause hyperuricemia, right? So now this is the point, when you get a patient with high uric acid, have you actually thought in all this direction? I know the list is quite exhaustive. I have not kept even total list, but the process is very simple, that we actually have to think any other causes there or not. Most of the time in practice, what you will find is the obesity or the metabolic syndrome causing asymptomatic hyperuricemia. Treat obesity with lifestyle modification, if required pharmacological modification, not the hyperuricemia. That is a byproduct. Okay, so we'll be going on that discussion when actually to treat and how actually to treat. But this is a very important slides. Now see, this is what I say for practice. Someone is here who is looking for what MCQ will come out of this, right? So much can come, and it is kind of terrible slide if we are making MCQ out of this. But a very important comes is the low dose aspirin. In high dose, it is actually, it reduces the uric acid level, but in low dose, it increases. There is one more MCQ, what I exactly remember. A patient is on this and this who has myocardial infarction and all. Patient is on aspirin and uric acid levels comes to 8 or 9 something. Shall we stop aspirin? No, never ever do that, right? We can't do that. Fine. So this is very important point to remember, that we have to actually consider the cause. Now this happens during the ATT treatment, right? Someone's uric acid goes high and we actually monitor sometimes. The uric acid is 9 or uric acid is 8, right? So we start febuxostat, and that is terrible mistake. Okay, why it is terrible mistake, we will understand very soon. It is not that I started a drug which caused hyperuricemia tomorrow, day after tomorrow. It caused gout after 5 days. No, it is a long process. So you do not treat, because if their pyrazinamide will be out in 6 months, 2 months, right? So why you are bothered even? It's just one report which is positive and which is a physiological effect, right? You can't stop pyrazinamide just because you see the uric acid 8. If patient developed the episode of gout, he must be predisposed to that part, and that might be additional trigger. That is a common sense we have to use. That time you are treating like you are treating a gout, I am fine with that. Fine. So these are the important points what we have to consider for your practice. Now going to the next, and I will say this is the slide exactly what it is showing. Just do that. Take deep breath and understand what is a natural course of hyperuricemia going to gout or going to do any damage. Because the number of students who are in meeting right now, we are around 36, it is showing, right? So if we really do uric acid for all 36 at present, we will get one value, right? According to that value, what is the chance of developing gout, we are going to see there. So what value comes to you and how you are going to treat yourself, because see, it is always the empathy, right? How you treat yourself, you treat others. So you will be able to do more logical science that what actually happens and what you can do, right? So first stage is hyperuricemia. Suppose I did an investigation for this 35 36 people, one or two got hyperuricemia, or maybe what number of people got hyperuricemia. Then someday they may be not or may develop gout episode, and then it will go to the chronic gouty arthritis and tophaceous gout. Will everyone go? No one has answer to this part. Okay, so this is quite tricky. If I am at the stage of hyperuricemia, do I need urate lowering therapy? I do not have answer for that. Why? Because there are very good studies which tells, if suppose your baseline uric acid is 9 milligram per dl or more, your annual gout incidence is 4.9%, and at 12 years you have 20% chance you will develop a gout episode. Okay, so the 80% will not develop gout at all despite they have uric acid level more than 9 milligram per dl. Okay, now it is something that we say ki, if I come in the 20%, how can you tell even that I should not take medication? Okay, you do take medication, right? It may or may not delay, or I am not sure how compliant you are to medication, and your chance was just 20%. So in an individual level, still it is debatable. But if I tell that you are running an institute or you are a government authority who is supposed to decide whether this febuxostat or allopurinol will be free or not, will you provide it free? No, right? That's how the institute works. That's how the things work, right? That's why you use logic. So are you telling me that you should not do anything when uric acid is more than 9 milligram per dl? No, I didn't tell that. I'm just telling that if asymptomatic febuxostat and allopurinol does not come in picture much. Okay, if your uric acid is between 7 to 8.9, at 12 years, chance is just 12%. If it's less than 7, annual gout incidence is just 0.1%. There is a very beautiful study in Nature Review. If a patient has uric acid more than 9 milligram per dl, at 15 years, the chance of incident gout is less than 50%. It's like flipping a coin, right? So it is not subclinical gout where you can have uric acid deposition, but no clinical episode, it is 15 to 40%. So this is not the everyone is going to develop episode of gout. So when you actually counsel the patient of hyperuricemia, your thing should be clear. You don't confuse them with the numbers too much like that. I'm talking to you because we all are doctors, so we can discuss this part. But you should have a common logical sense that if we start this febuxostat for everyone or allopurinol for everyone, who is actually getting benefit? Is it a patient or is it something else, right? So we have to be quite logical in treating. I have not told that we do not treat this. I am just telling you do not treat it with urate lowering agent. We'll discuss further how actually we treat it. Okay, fine. So now the question comes that those 20% or 12% who develops gout, are they special? Like today we did this uric acid for all of us, and few of us may develop gout. Okay, so are we really special? That what are the factors? Now see, factors are so many. Some you can prevent, some you cannot prevent, right? So there are genetic factor, male sex, ancestry, and there are certain genetic mutations. We cannot change much about this. Medications, yeah, we can be smart here. Diuretic, cyclosporin, tacrolimus, pyrazinamide, ritonavir, whatever modifications are possible, we can do here for sure. Dietary management, red meat, seafood, out of all alcohol, beer, all spirits, and sugar sweetened beverages. These are the key culprits which keep adding your uric acid pool a lot. So if you get a hyperuricemia, these are the food and the drinks to avoid for sure. Okay, you have to be very careful while you are advising or while you are talking to your patient. Okay, so this is very important point, or there is very important because their patient does ask you, right? Okay, what we should not eat. This is must not eat thing. What we should eat, I will discuss this further. Okay. And there are other part, like when age is increasing, menopause is there, CKD is there, overweight, obesity, hypertension, hyperlipidemia. There is a big list. So what I say here is, when you get a patient with hyperuric acid or high uric acid, if there is one of the factor here which you may be able to modify, you should modify, right? Because if I give you example that a patient who has CKD post transplant and all, he is on this one of the drugs, I won't chase that much. That is the part that I cannot stop drug. Uric acids are going high and high. That is the point I start urate lowering agent. Okay. So there are certain conditions where you cannot avoid. That is the point it will actually benefit. Otherwise, it will not benefit. So these are the factors. From high uric acid to gout, it can go. And we actually have to be careful that if we can address this, this is the way to do medicine. It is not, your answer is not lying in that allopurinol or febuxostat. Now, see, before I go in management, I have a very simple question. Like why you are not, why you are against those drugs that allopurinol, febuxostat you have used a lot of time, right? It usually does not cause any problem. Things are actually completely fine taking those drugs. It is not even that expensive. So why you are not advocating those drugs, which is little easy option rather than modifying diet and all? Okay. So the answer is very simple, that I'd like to follow science. That is a very simple answer there. Something is not needed, it's not. If it's not prolonging life and all something, any benefit it is not giving, it is not needed, right? It is same story with screening patients with PSA, right? Prostate specific antigen. I do not know what we are doing with that. Okay. So if you read really about the trials of PSA, you will actually realize that why did you even order that? The same story is with me for uric acid, right? So now this is the last few points, that the management. How do we manage? Now your patient who has been referred to you for high uric acid level, or is your regular patient, he did the report or you ordered the report and uric acid has come high. So how do we manage it? Now, let's go again for a concept that what do you mean by high uric acid? Okay, someone will tell ki in first year MBBS it was taught for male it is a different range, for female it is a different range. I agree with that. Specifically before menopause it is completely different because estrogen has a lot of role to play there. Okay, so the key thing to remember, the uric acid is actually crystallizable at the level of 6.8 milligram per DL, irrespective of patient is male or female. Okay, so above 6.8 is something, a worrisome thing, where the problem or the chance of gout in future can be there, or uric acid nephropathy or urate nephropathy can be there. It is not proven, but this is a physiological state. It tells. Majority of the guidelines tells asymptomatic hyperuricemia to be diagnosed when level is 8 or more than that. Okay, so 8 milligram per DL or not. Why I'm telling that? Because by chance, if you are treating or if you are following up a patient of asymptomatic hyperuricemia, your target uric acid level is 8 or less than that. Once patient develops gout, the target level is less than 6, or according to some guidance less than 5. So we have to be very clear what is target, right? We just can't treat कि चलो ये चालू कर दिया, we started this, we started that. No, we have to be very specific on our target, and that's how we should treat our patient. So before we talk even about the drug therapy, what are the non-pharmacological management of asymptomatic hyperuricemia? And that is the main part. First, educate the patient. See, your chances are not very high if you are not treating it. Recently, I saw one IS officer and I have stopped febuxostat. So my confidence is, it's not overconfidence. It is just science. Okay, otherwise I can lose my career. I understand that part, right? In India, it may happen. But it is very important to educate them that if you just modify few things, this is possible. The lifestyle modification first is the complete stoppage of alcohol, and some people get offended that how can you tell me not to drink alcohol, right? It's a very important question. And he tells me, okay, if occasionally I want to have a drink, or if I'm taking regular, and what is the most preferred drink? Okay, I'm not promoting anything, but it's a red wine which is preferred over anything else. Beer is absolutely no. It has more guanosine, more chance of getting to uric acid, and more chance of attack. Okay, so it is like smart alcohol consumption. It's a moderation. Dietary changes, what we already discussed, no to few things, and that few things include, one important point is red meat, seafood, and any drinks which are what we say the this all soft drinks or the beverages, or which are kind of juice and all, right? So that is not allowed because there is a lot of extra sugar. Patient should be involved in regular exercise. Weight loss is one thing which is directly shows relation that if weight is lost, uric acid will come down. You actually have to smartly see the drug list of the patient. If patient has any other comorbidity, if you can change something diuretic to losartan, it is the best thing you did to your patient, right? Because diuretic cause hyperuricemia, where losartan helps to reduce uric acid with the urate 1 channel. So smart drug choice, if your patient is hypertensive or diabetic, then losartan and SGLT2 inhibitor are two drugs which are shown to reduce uric acid level. So this is the first part you are going to do. And this is a very important concept we have to understand. Fasting does not mean eating fast food, right? And second important concept, what I keep thinking, now there is a trend of intermittent fasting. Okay, just think it very properly. Is it intermittent fasting or it is intermittent eating? Okay, because most of the patient fails at that point. It is allowed. What is not fasting time? Now you eat everything, and if food is terrible like that, what we discuss, then there is no point of having that intermittent fasting, right? Because initially, I think 2 years back, it was hyped too much, even in all the fields, cardiology, rheumatology, nephrology, everywhere, that okay, intermittent fasting, even in oncology, that it helps. It helps. Now, if you see last 6 month paper, it is coming down, and that's how the world works. Okay, when I was in MD, I was actually taught that when you have an episode of gout, do not start that urate lowering agent. Do not start febuxostat, because if episode is there, it will further reduce and there will be new episode. And actually, I was stressing too much on that while teaching my interns also. But today I'm going to teach you something different. So we just have to be little humble and see, okay, it's science, medicine, which is evolving. So let's do as per the best practice without forgetting the common sense. So this is the management of asymptomatic hyperuricemia. Is there any role of febuxostat, allopurinol, or any urate lowering agent when you have a patient with asymptomatic hyperuricemia? Yes, it is there. That is in next slide, but you will realize it is not much. So the pharmacological therapy should be offered if we get a patient who has decreased uric acid clearance. For that, you actually have to do 24-hour urine, uric acid, and creatinine in a level as well as in the serum, and then you have to find it whether the uric acid clearance is reduced or not. There can be genetic causes or there can be monogenic disorder like this. In those conditions, it is actually advisable to give it. If we really do this enough workup, that does not come in a routine OPD. But when you actually are allowed and you're working in a good institute or a setup where things are easy to get it done, then this is the point where we should be looking for. There are other things. There are episodic or sustained hyperuricosuria. There are rare monogenic disorder like HGPRT deficiency or the PRPS overactivity, glucose phosphatase deficiency. This is too logical, but I really want to take a small idiotic break here. This is deficiency and this is overactivity because that's what the MCQ means, right? There are certain clinical disorder like myeloproliferative, lymphoproliferative, hemolytic down, or glycogen storage diseases. If they are not manageable, you should start urate lowering agent. In this three, there is no doubt you should start. But here, if they are not manageable, you should start urate lowering agent. So these are the only indication where you do not have symptomatic hyperuricemia. By that I mean no episode of gout, no nephrolithiasis, which is attributable to uric acid stone, and the third part of the chronic urate nephropathy, if it is proven by biopsy. Then these are the conditions where you should actually treat. The question is very big that, okay, if patient has CKD, whether to treat or whether not to treat. Okay, and this is again, there are two big meta-analysis in that some shows benefit, some does not show benefit. The best in clinical practice, leave it to nephrologist, but in your MCQ, still answer stays no, that it is not recommended treat. Still, there are certain bodies which tells that if the level is above 11 or 9.5, you may treat the asymptomatic hyperuricemia in CKD. But even if I can remember my residency and my post-residency practice, every CKD patient, it was there. Okay, but we actually have to start thinking and being careful, because in practice it always happens. We keep observing people and we keep following people, and some other day we develop that sense, okay, he also must be doing same by following people, right? But someone has to read. Okay, because it's a pill burden. Now if I think that, okay, my patient is receiving that allopurinol 100 mg BD, but if I see the list in a CKD patient, how many drugs are there? So much. So then my logic should come that whether I can do something with the pill burden or not. That is also a component, because we never walk in the patient's shoe. Na? So we do not know how much medications are actually going on there. So that is one concept I'm realizing that matters. So if it's not supported by science, I will be just little back that no, this is not required. But in clinical practice, it is always nephrologist decision, which I leave up to them. So this was the management of asymptomatic hyperuricemia. It is mainly non-pharmacological management. I tell not to start ULT, but I tell this is must. The asymptomatic hyperuricemia is not something कि आपको कुछ like you do not have anything, so you don't come to me now. It's fine. No, they should be following all this part. Even you should be targeting uric acid level to be less than 8. That's how you manage a patient. Okay, because asymptomatic hyperuricemia is a symptom, is a like presentation of asymptomatic patient with some problem in the body. That's what we are managing there. Okay, so that's a very important point to consider. So now how do we manage gout? The same line, the education, lifestyle modification, drug list, smart drug choices, and very important here will come, even it can be implied there also, what not to eat. You already know what to eat. Always fruits over fruit juices, the cherries, the less ripe fruits, the dairy product, dash diet, and vegetable and fruits. This is actually very helpful, and it has been studied very extensively. It is told that it is helpful. I have seen in my practice two things. The pulses, right? The people completely stop. That is not allowed in your gout. Okay, that is completely wrong concept. Okay, it has to be, it won't cause any problem. It can be taken without any problem. Second thing, there is a concept that lemon and all should be avoided, or even orange, mosambi and all. Okay, that is also completely wrong concept. There is even a body which tells the vitamin C is a good thing in this patient. So it is actually allowed in a way. Okay, I am not telling to add you that tablet of vitamin C, which is such a big tablet for a patient, right? Don't add that, but vitamin C is good. Okay, because this is the actually whatever we talk about urate lowering therapy and all for a patient, this is the part what to eat, what not to eat, and he always gets confused because our information, which is scientific, which is not easily available, but a non-scientific information is easy access on your fingertips, on your Google and all, right? And there are so many beautiful YouTube videos also. They will show this decision, don't eat this, don't eat that. Okay, but you have to take your patient in confidence that we do science here, and that makes a lot of sense because it gives you a way of living life, right? Other than what is the point if I'm not hitting all these things. Okay, so this is maybe a little physician inside me or a little gujju inside me who is telling that food is okay. Be smart in taking choice rather than just taking everything or avoiding everything. What to drink? Water. Okay, that is a simple answer. Water is the best thing to drink. Low fat milk, dairy products are good. If alcohol has been given choice, it's just red wine, cherries are good. Okay, so this is the point, and this is the part will be very important in managing your patient with hyperuricemia. So now next comes, okay, this I have just hidden the brand name here. I'm not sure whether it can be a problem or not. So we have some concept specifically in Gujarat that alcohol-free beer, and there are certain people who does not take alcohol. They also, okay, there is alcohol-free beer. Let's try it. It's a terrible, terrible thing in hyperuricemia. So that is not allowed even, right? So that's, I will say rather than take a wine, man, why you are wasting on this, right? So this is, I am not again promoting alcohol, but this is a scientific advice. If someone is taking, should take that. Okay, fine. So now this is the point. How do you manage gout? This is from, again, American College of Rheumatology guidelines, which were published in 2019. And the world has changed from 2019 to today a lot. Okay, I'm not talking just about COVID. There is a lot of things which has happened in gout also that it has changed. So there are certain changes which may come in guidelines soon. But right now we will keep up to this because your examiners may be following this for your MCQ. So when there is a gout episode, what you treat with NSAIDs, colchicine, or glucocorticoids, which can be oral, intraarticular, or intramuscular. The colchicine and NSAIDs are better choice anytime than the glucocorticoids until unless there is a contraindication. Okay, so colchicine or NSAIDs. My personal choice is NSAIDs even over colchicine until unless patient has cardiac problem and all. There I prefer always colchicine to be given, right? So that is the point we have to keep. There is comparative study also, naproxen and colchicine, what is better. In terms of side effect, naproxen was better. In terms of efficacy, both were equal. So whatever you choose is completely fine. When you start colchicine, one symptom you are going to tell your patient, if you develop diarrhea, you stop it. That's a very important symptom you are going to tell your patient, right? Second point, we have to remember that IL-1 inhibitors are a good when you have contraindication to all this thing. It is not available right now in Indian practice. If you can import the drugs till the drug comes, by the nature of history, your gout episode is over. So don't do that part, right? It is not available, but yeah, it is available for MCQ. Patient who receives NPO, it is okay to go for steroids. Okay, because this happens that, okay, patient has episode of gout and now that is patient is NPO, we cannot give colchicine, we cannot give NSAIDs, what to do? That's the point you go for the intramuscular glucocorticoids. Someone tells, can I go for intramuscular diclofenac? Answer is still yes. But if there is a problem or other things, then I will always go with glucocorticoids with more evidences there. Okay. Now, this is important in a clinical practice. You get a call of a patient or a relative that there is a gout episode. What is the non-pharmacological measure you can do? It's ice which helps, not the hot thing. Okay, it will be, the joint will be too hot. You don't put hot things on hot, right? It's the ice thing. Okay, the logics are different. It's a vasoconstriction. It's not something else. Okay, that helps here. So this is from a very standard guideline practice how you manage actually episode of gout, and it is must to know. We have discussed this in proper detail in a class. Now second is the urate lowering therapy. Again, I am talking here is 2019. Okay, that if a patient has one or more subcutaneous tophi, start urate lowering therapy. If patient has radiographic damage by any modality, and specifically it's a erosion, if you can see on X-ray, start urate lowering therapy. If patient has gout flare more than 2 per year, start urate lowering therapy. So if it's the first episode, it is not compulsory to start urate lowering therapy. Again, if I remember time 5 years back, if I do not start that urate lowering therapy in your patient's next follow-up who had episode of gout and now it has recovered, I will be blasted during rounds, right? Why didn't you treat your patient? But the things keeps changing. So what I'm telling today so confidently might be wrong. Okay, you have to swallow your words back in medicine. That happens, but this is the current evidence which tells. If patient has experienced one flare but have infrequent flares, we conditionally recommend to initiate urate lowering therapy. So it is not must, right? Now, for patient experiencing their first flare, it is kind of, if you do not start, it is completely fine. Okay, but I will tell you a very important fact in clinical practice. You must start. Okay, the reason is not science here. Reason is compliance and patient's trust, and that is also part of medicine, right? So we actually have to have that. Now a patient who is Google freak and comes to you, no doctor, it is written in the pink part that it is against that you should not start over no ULT, what you will do there? Okay, then you actually, if you have this condition, you are saved. A patient who has stage 3 or more CKD, serum uric acid 9 or more, or urolithiasis, it is kind of, you have to start even if it's a first episode. Now the very important point here come here is, this is 1, 2 and 3 means all and except, it is MCQ point. Okay, and actually it screws that when you're teaching such a good science, you have to bring MCQ in between. Okay, you have to bring, that's a target, right? Fine. Asymptomatic hyperuricemia, which is defined here by Americans as 6.8 or more milligram per DL with no prior gout flare, no subcutaneous tophi, we recommend against initiating any pharmacological ULT, including allopurinol, febuxostat, probenecid, over initiating the agent, right? So whatever I have discussed, it is something evidence-based. And if you see the certainty of evidence, when you read guidelines, that someday you will actually focus on this PICO question also, which we all collectively ignored in our community medicine. It was the first there in PSM book, right? Then certainty of the evidence, how good it is. So if you see that not to treat hyperuricemia, certainty is too high. It's a high certainty recommendation that you do not start. It's good. Okay, so that's what we are trying to discuss, that it is not must to treat there. Now, what are the options of urate lowering therapy? This is again a pure MCQ thing. The detailed management I will discuss somewhere else. Allopurinol, most of the time we use that, or febuxostat, right? There is another agent which has come from Japan, which is topiroxostat. There are few other agents which is in Indian practice now, that is lesinurad, which inhibits OAT4 and URAT1 channel. You have losartan in your practice, fenofibrate in practice by URAT1. But if patient is on statin, do not switch them to fenofiber. Statin is still magical drug. Okay, so that is the point we have to consider. Same ranofilate, which is also a drug targeting URAT1 and OAT4. Then there is varinerad, and then there is a pegloticase, which is also available in India. Right now, as per my information, I know allopurinol, febuxostat, topiroxostat, pegloticase, and lesinurad. These are the drugs which are available in our Indian clinical practice. Okay, lesinurad is very good add-on agent when you do not have febuxostat or allopurinol working for your patient to achieve target uric acid. Okay, so before I really go here, what I told you, in asymptomatic hyperuricemia, your target of uric acid was less than 8. In symptomatic hyperuricemia or gout, your target is less than 6. It is again proven by study, target achieving versus not target achieving. I'm not telling clinical part, target versus no target. If target achieving is done, patient cardiovascular outcome, joint outcome, everything improves better. So it is always important to achieve target, and you should feel free to use this drug to the optimized dose. We mostly start with 50, 100 allopurinol, but you can go up to maximum 800. Most of the time we settle in 200, 300. Febuxostat, mostly we start with 40. You can go up to 120 maximum, but again, we settle most of the time with the 80 because patient target is achieved, right? Now, again, this is 2019 recommendation, and it was the point that allopurinol is preferred over febuxostat in a patient with this hyperuricemia and gout. Okay, even if patient has CKD stage 3 or more, allopurinol is preferred over febuxostat. This came because of a very big study which was published in the NEJM by the CARE group. Okay, you can actually see that study. It has patients number crossing around 3,000. Okay, and there it was observed that patients who were on allopurinol compared to febuxostat, cardiovascular benefits were good. But you know, this is all the game of data, right? After 1 year of that, there was again a very landmark study in Lancet which told no, febuxostat is equal to allopurinol when it comes to cardiovascular risk. Okay, so at present, everything is same. You use allopurinol or febuxostat, it's fine. But this one study, one guideline almost completely changed the practice. In India, it does not happen much, right? Who cares? These things are happening, coming into journal, it's okay. But in US, the distribution, or the other countries, distribution depends on the guideline. This is what is recommended. This is what we will give. Okay, and with the current scenario, I am not at all fan of the healthcare in US, right? So next, going for this CKD stage 3 and where it is there, again same, the xanthine oxidase inhibitor is preferred over probenecid, right? I did not talk much about the probenecid because I don't use it. It is not available even very easily. So it is very important to remember that probenecid is not a drug which is easily available. Even if you get the drug in your clinical practice, make sure if you are writing it, you are telling your patient very properly where it is available. Because most of the patient, once you start, once it is available, again, the availability is lost and your control is lost. So you don't do that. Okay, so that's a very important point again to take this part. Okay. Same way, the starting dose is 100 milligram per day or less in CKD patient, and 40 milligram per day or less in your patient with the febuxostat treatment. Okay, so next things come is, yeah, anti-inflammatory prophylaxis. This is again very important point to consider. When you start a patient, suppose like let's take a clinical scenario. You have a patient who has come to you with gout. Now the question comes how you are going to manage this patient. Okay, if it's your exam question, things are a little different. If it's your clinical practice, things are a little different. Because when clinical practice, patient is in such a pain, you do not tell them don't drink alcohol, don't drink Coca-Cola, don't drink this. No, you don't do that. First thing, you just reassure that we are going to take care of that, get some ice, apply there, and start your therapy with either NSAIDs or colchicine, or if these are contraindicated, with steroid, right? That's the first step you are going to do there. Now, the second question comes that, okay, urate lowering therapy, are you going to start today? Yes, it is to be started today. Okay, it's fine. Febuxostat or allopurinol, anything is fine. You can start that point. Okay. Now, when you have started colchicine or NSAIDs, when you are going to stop that? There are certain patients who will tell, now there is no pain, can I stop it? No. When a patient is on urate lowering therapy, you have to continue this anti-inflammatory agent, which can be either low dose steroid, which is 7.5 mg to 5 mg prednisolone per day, or colchicine, which is 0.5 mg OD, or your NSAIDs. You can use toricoxib or naproxen. There is nothing one NSAID is better than the other, but I always use long-acting NSAIDs because it's a once a day dosing. That's a better way, right? So that you have to continue for at least 3 to 6 months to prevent another flare on urate lowering therapy. If patient has presence of tophi, you have to actually continue it till the tophi disappears and 3 more months. So that is the exact guideline it tells. So on that day, if you are very clear that how I am managing the flare, yes, you have answer. How I am starting the urate lowering therapy, yes, you have answer. How you are going to give this anti-inflammatory prophylaxis and when you are going to stop, you have answer. What is your target? You have an answer, less than 6, right? And then after that patient pain is relieved, you start focusing on what to eat, what not to eat. This is how you manage a gout, right? So you read so much, but at the end of the day, you have to make a summary that tomorrow patient comes to me, this is what I am going to do. So that is very important in our clinical practice also. So now this is completely odd what I read 5 years back and what I'm reading today, that we recommend starting urate lowering therapy during the gout flare over starting urate lowering therapy after the gout flare has resolved. I was actually taught this, that wait for some day, 10, 14 days gout flare will be resolved. We will call patient back and then we will start either allopurinol or febuxostat. I have done that. This is written in my discharge summaries also. Okay. But practice do changes. I didn't have that much logic to think why we are doing it, right? Because we are going to continue that prophylaxis. So why we are doing it? But it was told by someone, it was practiced by someone, and we blindly follow. Okay. But someday you actually have to think what you practice daily, you should have logic, not just reflexes. Okay. Now this is the last slide. You have two drugs, right? Allopurinol and febuxostat. There is no smart choice. Okay. What you prefer is good. But if you really want to consider factors, let's compare them. The dosing is 50 to 100 milligram per day to start with. Maximum dose is 800 milligram per day. Usual dose is 200 to 300 milligram per day. While febuxostat, you start with 40, maximum is 120, and usually 80 milligram per day. Efficacy in urate lowering part, both are equal. Okay, and they are time tested with our Indian population also. There is no doubt one is good, one is bad or something. Safety, both are okay. Now here the question comes. So many people ask that allopurinol hypersensitivity reaction. Have you seen it? Very few. I have not seen it. I'll be honest here. I have written allopurinol like crazy. There's so much number, but I have not seen. If you ask someone who has experience of 20 or more than that years, he will tell, okay, I have seen one or two or something. So now the second question which comes, you have used lot of NSAIDs. Have you seen any Stevens-Johnson syndrome with that? Mostly answer will come, yeah, one or two, one or two, one or two. Have you stopped using NSAIDs? No, you have not stopped using NSAIDs. The same logic here. But point you have to be point which is to be taken very carefully is you do not start allopurinol with high dose, specifically in a patient who has CKD, right? This is the very important point. When you start allopurinol, you must advise them very carefully that if you develop them any itching, stop the drug and come to me. Okay, that is a must advice to be given when you start allopurinol. Okay, because that can screw your career. If patient develops Stevens-Johnson syndrome and all, it is quite difficult to treat even. So please advise that. Okay. I'm not still scared of allopurinol. I'm not scared of any drug. If you know the science, you're going to practice it. People are practicing it, right? But you have to be very good in your counseling when you're telling your patient. That is the point there. Then comes the pill burden. Sometimes allopurinol will go 2 per day, febuxostat 1 per day. For some patient, it may matter. So that also is the factor you will tell. Per tablet cost I have taken from online only or the MRP by the pharmacy. It's a 2 rupees for 100 mg. It is 8.3 rupees for 300 mg. And daily cost is 5 to 10 rupees. Here it's a 15 to 20 rupees. Maybe it does not matter to few of people, but it matters to others, right? So we have to be very careful that if that is also, this is per day cost I'm talking. So if it's a 300 rupees per month and around 4,000 rupees per year, it may matter for someone, right? With similar efficacy, similar things, it may matter for something. So it is very important to make a choice here properly. Now an MCQ before I complete, HLA-B5801, right? That is allopurinol. Before you start, we have to check. That is a recommendation for Han's Chinese. The Asians in that Han's Chinese, the Taiwan population, all not for us. Okay, it's a Han Chinese where it is there. It's not for us. Okay, so do not order that crazy HLA-B5801 because you want to start allopurinol. No, don't do that. You start febuxostat rather than ordering that, right? That's a correct way to practice it, right? So we have this full chapter available also on this app. And if you have any question, I think this is the time we discuss. Okay, I have few questions already there. I will go from very starting. That first is, can you explain what is a double contour sign? Okay, fine. I'll just go to that slide. Yeah. Okay. So see, this is what you are saying is the bone surface, what we have kept here, the USG probe. This is your skin. Then there is subcutaneous tissue. And then just 1 second. Yeah, fine. So this is what we are saying is the, like, where we have kept probe here, then there's a skin, there's subcutaneous tissue, and there is that muscular planes. And here what you have seen the last, this surface is your bony surface, right? Now above that is the actually cartilage, the black color thing. Now above this cartilage, what this line is there, it is the double contour sign. Here there is a uric acid crystal deposition, right? For that it looks as bright as that. There are two contours, and that's how it looks. The CPPD crystal has come little different change, which can be appreciated with the USG part. Okay, but this is what, if you see the normal USG, or you can just Google it right now, double contour sign versus normal, or double contour sign versus interface sign. There is a little complexity, but this is the first point to start something here. Okay, I hope it is clear. If it's not there, you can message here or you can ask directly. Okay, now a very important question: when to suspect chronic urate nephropathy? It is again a very difficult question to answer, or specifically in clinical practice. When we say you have a borderline renal dysfunction which are not explained, okay, what you ideally should do, it's a biopsy. On that you get the answer. The risk factor of hyperuricemia is there, which is like we discussed. If that is there, in presence of those risk factor, if patient has kidney dysfunction, yeah, that is the point to suspect chronic urate nephropathy. It does not have any different specific clinical presentation which tells, okay, cause of CKD is that or that, this, right? Even in diabetic, you do not have, you get every clue with that presence of diabetes. Now in our clinical practice, what happens is a patient, see, there are no absolute diseases. This patient does this, so diabetes won't be there. There is a diabetic, there is hypertension, then there is a borderline renal dysfunction. And we always put that, okay, this is diabetic nephropathy, and both can have proteinuria. So again, we put it's a diabetic nephropathy. In both, urinary sediment won't be there. So again, we put it is diabetic nephropathy, right? If we do biopsy, the things will change. The target will change to treat uric acid at that point. So that is the point we have to. Okay, now the very good question that febuxostat cardiotoxic drug. That was one thing which was thought, but which is not fact now. Okay, it is proven. And if you can send me just a message, I can send you references also for that. There was a study from care group. You should actually read in NEJM, and then you should read comments on that study, which will make you clear that how the things, or how the reading a paper actually helps you with the logics. It is not actually cardiotoxic drug. Okay, but for MCQ, if that is only option, I will tell it's cardiotoxic. Okay, fine. Then one episode, past history of gout, uric acid is 6. Now without treatment, should ULT be initiated? See, the guideline states it very clear. It is not needed if per your episodes are not 2 or more than 2. Okay, but that tells you again that patient had episode of gout, had hyperuricemia and everything initially, or maybe that process was there. That tells you a very clear thing that non-pharmacological management is something we are not going to miss. A smart drug choice of losartan I am going to keep if it is hypertensive patient, or SGLT2 inhibitor if it's a diabetic patient. For pushing for urate lowering therapy, I am really not going to give it. Even if it's MCQ, or even if it's clinical practice, if patient denies, no, I don't want to take it, I will say, okay, it's fine choice. Let's wait for the second episode. And when I tell let's wait for the second episode, I give them that naproxen or colchicine to be kept in pocket. The moment pain comes, Take that, and after that we are going to start. And okay, very important question. When to stop ULT? Okay, when to stop ULT? We do not stop ULT when we start once. Okay, there is no right now recommendation to stop ULT. That's what I'm focusing too much on, that when to start is an important question. Now see, if ULT started in a wrong scenario, it must be stopped. That's a clear cut question. Okay, so I've stopped so many times, and I think no company will like me for that reason, that he's stopping more ULT rather than starting more ULT, right? That's fine, we do science. Now here I will give you one scenario here, that a patient who comes to us, a young lady around 28 year or 34 or female, who was admitted with sepsis and AKI and all, uric acid level came to be 9.8. In ICU, febuxostat was started by XYZ, that contains us or intensivist or anyone in the world. He started febuxostat. After 3 days, the uric acid level improved, and we all celebrated the magic of febuxostat. Actually, you treated sepsis. Okay, that is a point. Now it's fine. Patient was on febuxostat, is on febuxostat. Patient got shifted to ward, and patient is getting discharged. You are making a discharge summary. You are again writing, okay, urate lowering therapy, febuxostat. He comes to you for follow up, and you do uric acid level. It is okay, 6.2 or something. You continue it. No, this is the at this point you stop it. It's not required. It was not the indication to start even. So it's a very important point. I get so many patients that, okay, some patient has Achilles tendon pain or something, who is a young lady who overworked or something, and then again the pain developed. Okay, uric acid level someone did, it came to 6.8 and started therapy with febuxostat. That's a complete rubbish indication. Stop it. If you are not confident enough, do the USG of that part and prove there is no uric acid deposition, and then you stop it. Okay, that is a very important point to go for. Okay, NSAIDs versus colchicine in acute attack. Efficacy, both are same. Side effect wise, colchicine related diarrhea is little more common compared to NSAIDs. Otherwise, both are same. Okay. One good point to remember here is, if the episode has passed 48 hours, then NSAIDs are better than colchicine. Colchicine works in very initial stage. And I think I put a question for you people now, that why colchicine will not work after 48 hours as great as it works less than 48 hours. Okay, because it's all about logic in medication. Right. When do we initiate ULT immediately in gout, and when do we delay? Nothing. It is completely our choice. We started immediately. Okay. How to manage tophaceous gout in CKD? Is there role of uricosuric in non-oliguric CKD? Wow. Right. Okay. See that the first thing is tophaceous gout and non-oliguric CKD. If there is a non-oliguric CKD which is going on, patient has tophaceous gout, the always first choice is you go with the conventional urate lowering agent, right? That is your agent with febuxostat or your allopurinol at maximum tolerable dose. If that is not helping, there is definite role of pegloticase. It is not from the very much starting you see the tophi and you start on that part. Okay, now a very important question. Topiroxostat versus febuxostat in cardiac patient. And I think I will give you this message very correctly. Please see the studies which are published in topiroxostat. The number of patient enrolled in the studies are not sufficient to make any interpretation. So I do not have answer to this. I will say both are almost equal. The answer with topiroxostat is it has not caused any harm. They are showing that QT prolongation is beneficial. Are you really bothered about that part? That's a very honest question. We all came to this part, that HCQ and QT prolongation. You start for so many patients in your life. Do you check even ECG before starting HCQ? No, we do not, right? So sometimes what has been shown by marketing things or the studies, we actually have to take with pinch of salt or lot of salt, that what actually they are showing. We have to be very judgmental in making that decision. Okay, so for cardiac patient, I will say for me both options are open. Topiroxostat is a good drug, but a costly affair. So you have to choose very wisely. Okay. Should we go for joint aspiration to demonstrate MSU crystal? Yeah, very good question, right? Okay, so I will say when I was working in institute, I had that thingy. I really have to see what crystals are there. Second thing, if my USG, MSK USG confidence wise, if I do not get double contour sign and all, then if you are suspecting a pseudo gout, yeah, that is the point. You should demonstrate whether this is crystal or not. Now let me ask a very simple question. How many labs do you know in your practice who actually does this polarized microscopy to demonstrate crystal? It is very, very few. There are few crystal, including uric acid, which you can see on light microscopy if the burden is good. Okay, but if burden is good, things are very easy. You see the tophi. Now it is just for our scientific fun we are seeing the crystal, or sometime for documentation, sometime for insurance we are seeing the crystal. So that is a point stays there. The MSU crystal demonstration is a gold standard, but not must in clinical practice. I think there's a lot of question. Yeah. Is any patient of tophi, we can start colchicine and ULT at once, or any other mobilization of uric acid from periphery parts? No, it is same as we manage all patients. You start colchicine and ULT. If you have to take advantage of your losartan and SGLT2 inhibitor. Otherwise, no other part. And any operative part done at this point, if it's infected, please do surgical things. But if it's not infected, you do not need it. It will increase actually. If someone coming with repeated episode of monoarthritis ankle toe without gout like appearance, how to deal with those episodes? Investigate properly. You do the MSK USG, you see it properly, and then you get the solution done for that. Okay, if there are repeated episodes, I will say they might be developing erosion at the end. So you do just simple X-ray, it will give your answer. You do sonography, it will show double contour sign. And now let me tell you a beautiful thing. If patient comes with great toe pain or the ankle pain, does not mean the uric acid has not been deposited in knee. So if you put even sonography at the knee, there might be double contour sign there. Asymptomatic uric acid deposition. That gives you more confidence that this is gout. The uric acid level might be normal as we discussed, but will come up after some time if you repeat it. Most of the time after 1 month, if you repeat it, will be little high. How do we approach ULT initiation in acute kidney injury if uric acid is above 11? It is as per GFR. There is complete clear guidelines. What is the GFR and what is the dose of allopurinol and what is the dose of febuxostat. Topiroxostat had that advantage that we do not need settling on that part. Okay. But otherwise, there is a complete thing. You can message me. I will send you. And if you are reading our daily points, it was 3 days back that what is the GFR and what is the thing we start. Okay. So even after achieving target, do we still continue ULT? If so, how much long? Your answer is very clear. When you get a hypertension control, do we stop it? No, we do not stop it. How long? For life. That is the answer there, right? Because of colchicine blocks neutrophil. Okay, we got answer also. Right. If there is no tophi and patient has oligoarthritis with borderline uric acid, first prove it is gout. Okay, you know how to prove it now by MSK USG, by radiography. You prove it gout and then you treat like it a gout. Okay, so see, the borderline uric acid is not a concept in a way to tell it is high or it is normal. That is the point, and it is all clinical. The first clinical diagnosis you have made, you are actually going to treat that. What is the indication for uricosuric agent in clinical practice? It all depends on availability. Okay, otherwise preference. See, when you have the pictures which are overproduced and all, if you are able to work up it, then it is there. Otherwise, no, it does not. Okay, I think I will keep it to last 1 or 2 question. Rapid lowering of urate level is associated with gout flares with an increased risk associated with therapies that more effectively lowers urate level. Correct, good. Okay, we did not understand this part. Yeah, this is the very important point actually. And this was a logic which was taught to me during my MD, that when you start this agent of febuxostat, allopurinol and all, your uric acid level is going to fluctuate. And when the uric acid fluctuates, it fluctuates from all the part, including the tophi which are already deposited, which were asymptomatic, or the gout or the MSU crystal which were deposited in another joint which were asymptomatic. So when you move it, the chance of crystallization increases with that. And to prevent that, you give anti-inflammatory agents so reaction does not come. Now, a very simple question. What does body react to? What is the culprit in here? So it's not uric acid, it's a crystal of uric acid. That's a MSU, monosodium urate. Whenever there is a monosodium urate inside the cell, in cytoplasm, there is an inflammasome activation. And that inflammasome activation will lead to activation of IL-1, TNF and everything. That's why that IL-1 blocking agent is a part of acute gout treatment, not the chronic gout treatment. So that is the actual part which has been told that at that point it is important. Okay, chronic urate nephropathy or tophaceous gout. Do we need to start NSAIDs or colchicine with Ualt? Yes, for sure, for sure. Okay, and till the tophi disappears, it has to be continued, and then after again 2 to 3 months. Febuxostat versus raspberry acid in TLS. I will give it to oncologist. Okay, they are the best person to decide. I do not manage TLS, but theoretically telling, you will need help of allopurinol and raspberry acid, which are fast. Even febuxostat is, it is a choice between this allopurinol versus febuxostat, raspberry case, when it is not helping. So I think let's end with the questions. And if anything is there, you can message me. Thanks a lot. It was wonderful to interact. Thank you.